And also special thanks to the moderator, Ashokan sir and Mani. And sincere thanks to our teachers who taught neonatology to me and give this opportunity as a speaker in this webinar. Okay, in the next 15 to 20 minutes, I'm going to highlight about the role of pediatrician during the delivery. So each and every newborn is a dream for a family. So the role of pediatrician during delivery is to give a healthy baby to the family. That means they are the persons which makes the dream to comes to true. So such a huge responsibility is there in the shoulder of every pediatrician. So pediatricians are always smart. Why? Because they think smart, because they will anticipate the problem, they prepare for the problem, and then they face the problem will be very easy. So delivery of the newborn is also a planned action. If you're not planned, you will be in trouble. Then the whole problem will start. So whenever you are going for resuscitation for any newborn, you should be planned. You should not be in tension. Why this planning is very important? Because 90% of the baby which is delivered, it doesn't have much need of much resuscitation. They need only routine care. This intrauterine to extrauterine process is a very complex one, and 90% they will transit without any problem. Only less than 10% needs resuscitation. Out of that, 8 to 9% need and some form of resuscitation, and less than 1% need extensive resuscitation. So we must categorize where the babies to get delivered in a primary care or a secondary care or a tertiary care. So this planning is very important. And so why this planning is very important? Because when you assess the sequence of physiological event in utero in asphyxia, so there is an respiratory babies having they have in utero respiration, the heart rate and blood pressure. So within a time period of less than 15 minutes or within 13 to 14 minutes, the babies see the pH is coming down from 7.3 to 6.5, and their blood pressure is coming down, and the heart rate is coming down, and they are no more breathing. So when the insult has been, if the insult is just an less than 15 minutes is more than enough to cause a massive insult, which causes a BP to get dropped, and having an the baby will be in bradycardia, and also there will be no spontaneous respiration. So this time is very important. So if you are not planned in a manner, if you already there is a compromised baby, we will end up in an asphyxiated baby. So their intact survival will be questioned. So planning is very important. So the role of a pediatrician in a delivery room is they make the dreams to come true. That means they should give a healthy baby to the family, which is the dream of an entire family. So what's a pediatrician role at delivery room? So before delivery itself, this planning should be started. So there must be anticipated, they should anticipate for the resuscitation, and they should have given antenatal counseling when they encounter any problems, and they should prepare for the resuscitation. So they taking care of many events, sepsis, temperature management, equipment, drugs, and main thing is they want to form a team, and every person in the team should be trained in NRP, and the team should know the responsibilities and how to perform the resuscitation. This is very important. These things should be done before the delivery itself. And another thing, during the process or after the delivery, they know how to perform the resuscitation, And importantly, and many times you are going to miss this, is a documentation of the things what we have done. So documentation is very important. And also, once again, counseling to the parents related to any ethical issues. And most important is giving an injection vitamin K and initiation of breastfeeding within an hour. This is going to be elaborated in the next coming 10 to 15 minutes. So anticipation for the need of resuscitation. So anticipation is, see, in this area we are going to discuss about the risk factors and antenatal causes. So we have multi-number of risk factors. So everyone knows that antepartum risk factors related to one maternal and fetal. So here, any delivery more than less than 37 weeks is going to be in risk factors, and more than 41 weeks is going to be an risk factor. And everyone knows that pH, GDM, fetal anemia, multiple gestation, polyuria, so everything okay, fine. When it comes to these two things is very important. Here, oligohydramnias, definitely many times they will miss it. And IUGR and fetal macrostomia. These, see, oligohydramnias with the intact membrane indicates there is an intrauterine fetal compromise. There is a chronic intrauterine hypoxia is there. So whenever I come across an oligohydramnias, whether check their membrane is intact or there is a leaky membrane. Okay, leaky membrane, then the cause would be in PPROM, then etiology will be different. Then the oligohydramnias with intact membrane, then think of there is some possibilities of chronic intrauterine hypoxia being operated in this baby. So these things should be kept in mind before going for the resuscitation. You must ask to the obstetricians colleague. So intrapartum risk factors, which is can't tell before the delivery, it is occurred on the process of the delivery. Any babies which is putting in vacuum or forceps delivery, and there isn't any abnormalities in fetal heart rate tracing, or suddenly you are not able to get an CS lumbar puncture, so they can convert, or any other cause they can putting into a maternal general anesthesia. Maternal magnesium sulfate can cause to depress the baby, and maternal narcotics within 4 hours of delivery, or any shoulder dystocia. These going to be an important things when the baby is not tried. So all the risk factors, antepartum and intrapartum risk factors, should be discussed, and you should have this checklist that should be anticipated for each and every baby, and you should discuss with the obstetrician, and we can go forward. So antenatal counseling, this is usually done when there is any problem during an antenatal period. If we are going to deliver a less than 1 kg baby, then we should counsel the parents regarding the survival, intact survival, mortality, morbidity, and everything. And if there is the patient agrees, okay, there's a good chance of survival, okay, then we can continue the resuscitation. If there is no chances of survival, then we should consult them, and then we can decide what to do after the delivery. So these things, not only here, if you are dealing with some surgical conditions like CDH, congenital diaphragmatic hernia, tracheal fistula, or any surgical conditions, or any soft markers which has been identified antenatally, you should get counseling before the delivery itself. Okay. And what are the preparations? So preparations for this delivery. So in this heading, we are going to have how we are going to prepare for an asepsis, temperature management, equipment checklist, and what are the protocol and team briefing. See, everyone knows this WHO's 6 cleans. So why I just put this in? Many a times we tend to, we certainly follow this clean hands, clean delivery surface, definitely follow this. And sterile cots, definitely will follow on clean cloth to wrap the mother and baby. It's somewhat putting in certain areas. And also clean cord cutting instruments. It's also sometimes, else you must have some problems in getting this clean cord cutting instruments and clean cloth, because many times in wherever in suburbs or even in urban, some areas, we tend to see that dressing the baby with an unsterile towel, which is more pathetic and has increased chances of more spreading of an infection. So the trend all should be kept kept in the check. So hand washing, either definitely you should have it elbow operated tap, and also you can have it on a foot operated tape, whichever is feasible, but you should have an elbow operated tape or an foot operated tape. So regarding this cleanliness, because we should have a separate scissor for umbilical cord cutting. So that's very important one. Because many times we see in a normal labor, we see that the same scissors which has been used for cutting and used for an episiotomy is being used to cut the umbilical cord. So we must use a separate scissor for cutting an umbilical cord. One. And another thing is, two sterile towel should be there, because many times we see that we find an unsterile towel to cover a baby. So temperature, you should be checked that room temperature should be 25 to 28, and for towel warmer should be needed. Now it should be kept at manual mode at 30 degrees centigrade. And another thing is, you should close the windows, and you should have switch off the fans. And this is one is an important thing, is equipment checklist. Here, things, if you are anticipating for a preterm delivery, you should less than 32 weeks, you should have a plastic bag. You should be kept ready to maintain the normal temperature of baby, also to prevent an heat loss. At the same time, it's very if you're having a suction with the pressure gauge, it's very easy, and you should be maintain the pressure at 100 millimeter of mercury. So blending and oxygen is very important. Many times what we find is, many areas, even in many corporate hospitals, we find that in the resuscitation area they have one central oxygen and suction. It's hard to find an air. Without air, it's difficult to get a blending. So try to make things with the first visit we are not able to get them to come to a track, but consecutive counseling we can able to make them to have a air at a resuscitation area. And oxygenation, definitely we need a pulse oximetry. And many times we find that they have all laryngoscopes, ET tubes and everything, but what they find that they doesn't have scissors to cut that plasters. So make sure that these things should be available at that resuscitation area, or you should have taken that some resuscitation boxes, resuscitation kit, where that you can place all the checklists and you can put all the equipment in. So, and last, we can take only two drugs will be used. Apart from oxygen, you can use adrenaline and normal saline. So definitely there's a need for an oxygen blender, plastic bags, and PEEP generating positive pressure ventilation device, especially for an preterm. See, this is a resuscitation box. We can have it a checklist with the resuscitation box, and with the one first layer we have some things, and beneath we can have one stethoscope and endotracheal tubes. So before going for any resuscitation, checks assess the functionality of that bag and mask, whether the bag is functioning is there or not. And regarding this blending, this oxygen blender is essential to provide an graduated FiO2. So we need definitely we need an air source to blending that oxygen. So here we have three things: self-inflated bag, flow-inflated bag, and TP resuscitator. So only this flow-inflated bag and TP resuscitator can generate an PEEP, but self-inflated bag won't generate an PEEP. So when you are planning for to deliver an preterm baby, you need to have an positive pressure ventilation device with an PEEP generated bag. So what's the expectation? We need an central oxygen, central air, and central suction. But in reality, some centers we have central oxygen, central suction, But many times we find in areas where we have only B-type cylinders and bubble suction unit. But one of the thing is accept the reality, don't get tense more and don't go and fight it with any of our colleague, and try to make them to change and come to into our track. That's the art of communication. So protocol, NRP protocol, it's itself a single day program. So it's very difficult to things we need and protocol which should be placed at the resuscitation corner. So we need a resuscitation team. The team members usually pediatrician will be a leader. We have nurses and accessory workers will be there in a resuscitation team. How many members in the resuscitation team will be depends upon that risk factors. How many live births we are going to deal. For example, if we are having no risk factors, we need only one team member will be more than enough. But we have any risk factors, we need at least 2 team members for pediatrician and staff nurse. If you are dealing with an triplet or twins, we need more members, 2 to 4 we need. So we must plan according to team members, how many members need for an resuscitation should be planned with priority, and we must discuss them, what is the roles and what is the responsibilities of the each members and what they should do, and pre-resuscitation team briefing. So fixing the responsibilities and what are they are going to progress. Everything should be done before the delivery commences. So with the equipments checklist, with the protocols, with the team, yes, we are ready to face any problem. So then how to perform on resuscitation here. So in this area, we have discussed only on routine care, when to start bag and mask, because it's a very elaborate one. We are just brief about and what's the need for this. So here, term breathing, you see this one is a good tone. So you should have a baby should have a good flexion at all the area. It indicates a good tone. This indicates the baby can be in the mother's abdomen. Okay, there's no problem. We can do, baby will be better with only in routine care. So what is the routine care? We want to try give maximum attention to the head. The vernix is vernix present means don't clean it. It prevents an hypothermia. So here you want to use 2 sterile towels. One towel will be dried and should be put it and make another towel to cover it. So to prevent an hypothermia. If at all we need an suction, please give us set us a pressure between 80 to 100 millimeter of mercury. So here, see, this is the poor tone. There's no active fluxion is there. This will be in flabby. If there is there, you can don't go directly with for bagging. Follow the routine steps and stimulate the baby, either flickering or rubbing at the back. So even after that, this baby is not having. If you are assessing if your baby is not having a heart rate or breathing, then go for an positive pressure ventilation. Try to fit a appropriate mask. Try to bag at that in the head end, and usually it goes the way like breathe 2-3, breathe 2-3, like that you are going to give a bag. When even after that we are not going to get any improvement in heart rate or any other things, you just do an ventilator corrective steps using an MR SOPA. That's simple. It's a mask readjustment, repositioning of the head, suctioning in the mouth, and when you open a mouth or increase pressure or look for an alternate airway like laryngeal mask airway or a ventilation. So the pulse oximetry, when will the pulse oximetry come? It's simple. If you are going to bag, the pulse oximetry will come. Or if your baby is cynosed or if the baby needs an oxygen, then there is a pulse oximetry will come. Usually it's an right upper limb pulse oximetry. So there is some targeted saturations. We need to have a targeted saturation of 85 to 95 at 10 minutes. So be patient. Don't go with the numbers of the saturations. And chest compression. So even after effective ventilatory corrective steps and the heart rate is less than 60, then you can go for chest compression. It's an 1 and 2 and 3 and breath. It's usually 3:1 chest compression and things. It will be elaborated in an RP. So it just been machine here. We are going to use only 10,000 dilutions of adrenaline. Usually it should be given with an IV or an umbilical. So if you are going to intubate, choose an.
2 minutes, Senthil.
You can take an weight category. So it's a very simple one. 1 to 2 kg you can go for 3. 1 to 3 rules. So for 1 to 2 kg you can go for 3. If less than 1 kg, 2.5. More than 3, you can more than 2 you can go for 3.5. So then when to discontinue resuscitation? So this resuscitation should be discontinued when you are after an effective resuscitations after 10 minutes. If they are not finding any signs of life, heart rate or respiration, we are going to discontinue resuscitation. So when you are going to withhold resuscitations, so usually it's legal, if legally acceptable, and if there is a complete agreement between the healthcare providers and the parents, and the baby's outcome is going to poor, then we can discontinue that, withhold the resuscitation. So non-initiation of resuscitations mean when there is an gestation is less than 23 weeks or 400 grams or any anencephaly or trisomy, we are going to withhold the resuscitation. So these are very important ethical principles in resuscitation. So patients should have rights to refuse or choose their baby's treatment. So that should be kept in mind. One. So whatever things we are going to do is the best interest of the patients. We must be deliver the best one to the patients, and do not harm anything. You do not harm that baby. There is a fairness and equality in providing a service. So dignity of the patients, families, and caregivers should be taken into mind, and truthfulness and honesty between the parties should be also taken into considerations. So documentations. So these we have it in our medical college as well as in Kaveri Hospital. One side we totally will have an risk factors related to antenatal risk factors, and another side is baby details, time, birth, and very important, we need to give an Apgar for every baby. So we need to ascertain a gestation age and anomalies, checklist for anomalies, and vitamin K detail whether they are given or not, and what you are going to do. This everything should be there and should be documented and should be kept in and to the owners with the mother case sheet, and if at all the baby's admission should be sent to the NICU also. Regarding Apgar, it's an 1 minute Apgar indicates an intrauterine depression, and 5 minute Apgar should indicates an effectiveness of resuscitation. So try to put an Apgar for each and every baby, the two Apgar, 1 minute and 5 minute Apgar. So that these documentations, and also we just have we'll document that for suspecting preterm, whether they are given in antenatal corticosteroids or magnesium sulfate is being given, should be documented. And many important things, vitamin K given as well as breastfeeding within a minute, which is also will be documented. And that's very important because initiating breastfeed is very, very important. And vitamin K prophylaxis. So usually we will only given vitamin K1, but weight is birth weight is less than 1 kg. We are going to give an 0.5. If it is more than 1 kg, we are going to 1 milligram. So initiation of breastfeeding, definitely in a routine care, put the baby in a mother's abdomen. The skin-to-skin contact itself favors the babies to get milk within an hour. And initiation of breast milk within an hour, it's also not only good for the babies and also for the mother, which prevents an PPH. And it initiates the baby to breastfeed further. So it prevents a formula feed to come into to the baby side. And once again, the take-home message is: so anticipate, prepare, and perform the resuscitation, and document it. Counsel the parents, considering the ethical issues, and give an vitamin K and initiate the breastfeeding within an hour. Thank you. Thank you for giving an opportunity as a step to improve your neonatal health. Thank you.
Thank you, Senthil. That was a wonderful, nice touch with the Mahatma Gandhi. I think it's very important, isn't it, to have a pediatrician at all deliveries, even though you say 90% of them don't need any support. But obviously, we want every baby to be accounted and to